All right, welcome to this explainer. Look, I am so incredibly excited to have you here today because we're tackling a topic that, let's be honest, a lot of people absolutely dread. But it's something every single one of us in healthcare relies on completely: clinical biostatistics. We're going to see how biostatistics isn't just a bunch of dry math sitting in some dusty textbook. It is literally the foundation of real-world patient care. Every time you order a test, interpret a new study, or prescribe a medication, you're applying these concepts. So my goal today is to give you the structural logic to see right through those numbers. So here's our roadmap for today. We'll start with the foundation of diagnosis, then look at screening versus confirming tests. After that, we'll dive into predictive values in practice, how to spot common study biases, and finally, we'll wrap up by calculating true risk reduction. Okay, section 1, the foundation of diagnosis. I want to throw this scenario at you right off the bat. If a diagnostic test is, say, 87% accurate, what's the actual chance you have the disease? Let's set up a real clinical dilemma. A 25-year-old patient comes into your office with a fever and a sore throat they've had for 3 days. You're suspecting streptococcal pharyngitis. To confirm it, you use this novel test that boasts a positive predictive value of 87%. The patient tests positive. So, what does this actually mean for them? Well, here's the kind of surprising truth. A positive predictive value, or PPV, of 87% means there's an 87% probability that the patient who tested positive actually has the condition. But flip that around. It means there is a 13% chance that they absolutely do not have the disease. You know, accuracy is a term people throw around all the time, but it really just refers to a test's ability to yield results close to the real value. The positive predictive value, that is what actually matters to the patient sitting right there on your exam table. It answers their most immediate, anxious question. I tested positive, but do I actually have it? Moving right along to section 2, screening versus confirming tests. Here, we're comparing two absolute titans of diagnostic medicine: sensitivity and specificity. Think about a 62-year-old guy whose wife recently had colon cancer, and now he wants a screening test. For screening, we want a test with high sensitivity. Why? Because we want to identify early cases and cast a wide net to capture almost all affected individuals. That means we need the lowest possible false negative rate. Now contrast that with researchers developing a new biomarker to actually diagnose congestive heart failure. They have a marker with 93% specificity. The higher the specificity, the better the test is for confirming the diagnosis, because it guarantees a low false positive rate. In practice, these concepts are always dueling. We screen with high sensitivity to catch everyone, and we confirm with high specificity so we can be absolutely sure. All right, section 3, predictive values in practice. Let's actually walk through an asthma diagnostic study so we can visually lay out the raw data. We've got 100 patients with confirmed asthma and 100 patients confirmed without it. Out of those with asthma, 56 tested positive. Those are our true positives, but 44 tested negative, making them our false negatives. In the group without the disease, 88 correctly tested negative, our true negatives, but 12 actually tested positive, giving us 12 false positives. This simple 2x2 table, it is the absolute bedrock of clinical biostatistics. So, what's the practical application here? Let's crunch the numbers. The positive predictive value is true positives divided by all positives. So 56 divided by 68 gives us 82%. This means if your patient tests positive, there's an 82% probability they actually have asthma. The negative predictive value is true negatives divided by all negatives. 88 divided by 132 is roughly 67%. The sensitivity is true positives divided by everyone with the disease, 56%, and the specificity is true negatives divided by everyone without the disease, 88%. Do you see how seamlessly the whole clinical picture emerges right from the raw data? Let's apply this concept one more time, but with a massive Hodgkin's lymphoma study that compares a new diagnostic test to a standard lymph node biopsy. Out of 1,000 patients, take a look at where we spot the 118 false positives. These are folks who tested positive on the new test, but their biopsies were ultimately negative. Using this exact data, we calculate the specificity by taking our 382 true negatives and dividing by the 500 total people who definitely don't have the disease. That gives us roughly 76%. Seriously, every single time you read a diagnostic study, I want you visualizing this exact matrix in your head. Which brings us to section 4, spotting common study biases. The crucial point here is that even with perfect math, research can fall into some serious traps. The first one we need to talk about is lead time bias. Let's say a medical center develops a screening biomarker for ALS and they test everyone over 50. Suddenly, the data shows that survival for ALS patients has increased by 2 whole months. Sounds like a miracle, right? Well, not exactly. ALS currently has very limited treatment options. Because they're screening, they're simply detecting the disease 2 months earlier. The patient doesn't actually live any longer. They just know they have the disease for 2 extra months. That is the illusion of lead time bias. Next up, we have recall bias. Just imagine a study asking 1,000 congestive heart failure patients alongside 1,000 healthy controls to fill out a survey detailing their past history of using painkillers. The researchers look at the data and conclude CHF is strongly linked to analgesic use. The trap? Well, patients dealing with a serious condition are desperately searching for answers, so they're way more likely to remember and over-report taking pain meds compared to healthy folks who probably just shrugged off a headache 5 years ago. Survey studies are notoriously prone to this exact bias. Now, let's talk about confounders. Honestly, these are the hidden saboteurs of clinical research. A confounder is basically an external variable that's tied to both the risk factor you're studying and the disease effect you're measuring. If you don't control for confounders, they can completely distort your data. They'll make totally harmless behaviors look incredibly dangerous, or ineffective treatments look like absolute miracles. Let me anchor this with a pretty wild clinical example. Say a medical student reviewing the literature finds this unexpected trend. People who sit and watch more TV seem to have an increased risk of bladder cancer. I mean, is it the radiation from the screen, the prolonged sitting? Nope, it's a classic confounding variable. We know smoking is a major risk factor for bladder cancer. If people who sit and watch more TV also happen to be more likely to smoke cigarettes, it creates the perfect illusion that the television is causing the cancer. And that leads us perfectly into Section 5. Calculating true risk reduction. We're going to set up a massive clinical trial comparing a brand new statin to an older one. The goal, obviously, is preventing cardiovascular events. Our baseline data reveals that 12% of patients treated with the old statin suffered an event, but in the group taking the novel statin, only 8% suffered an event. Okay, so we have our raw baseline data. Now let's look at how this exact study is going to be marketed to you. 33%. Now, that is a stark number. This represents the relative risk reduction. How did we get there? Well, the risk dropped from 12% down to 8%. That 4% drop is exactly 1/3 of the original 12% risk. So, the pharmaceutical company can legally and accurately blast out a headline saying, "New drug reduces cardiovascular events by 33%. And wow, it sounds like a massive, game-changing intervention. But hold on, I want you to immediately contrast that with this number right here, 4%. This represents the absolute risk reduction. It is literally just the raw mathematical difference between the 12% who had events on the old drug and the 8% who had events on the new drug. 12 minus 8 equals 4. Let's shift our focus to what this actually means for you and your patients. These two starkly different numbers, a 33% relative reduction and a 4% absolute reduction, represent the exact same clinical study. Framing is absolutely everything. While relative risk sounds incredibly impressive and is fantastic for getting headlines, understanding the absolute risk is vital for making actual clinical decisions. Because think about it, if the new drug costs 100 times more and comes with severe side effects, is a 4% absolute improvement really worth it for your specific patient? That is the question Biostatistics empowers you to answer. And that brings us to the end of our explainer. But before you go, I want to leave you with this final, somewhat provocative thought. The next time you see a medical breakthrough on the evening news or front and center in a journal, are you just going to accept the headline numbers? Or are you going to dive in, look at the predictive values, hunt for those hidden biases, and calculate the absolute risk behind the math? When you apply this kind of structural logic, you don't just read studies anymore, you decode them. Thank you so much for learning with me today, and I'll catch you in the next explainer.